Hi, everyone. I'm Charlie Pollack, emergency medicine specialist from the University of Mississippi, and a longtime trialist and medical writer about the scourge of venous thromboembolism. I hope you've been enjoying our series. There are 5 installments, so wherever you're joining us, be sure to check out the other 4 on the Academic CME podcast and also as a video podcast on Spotify. This series is supported by an independent educational grant from the Bristol Myers Squibb Pfizer Alliance, and we're happy to bring this to you from Academic CME. Our focus today is on risk assessment and also incidence of venous thromboembolic disease. It's a little bit of a dry topic, and the incidence and the risk factor profiles completely overlap. You can't talk about the incidence of VTE without saying in what population. Are you talking about older patients, younger patients, obese patients, smoking patients, patients with cancer, patients who've been injured, patients who are immobile for other reasons, male or female? All of these things play into the risk of venous thromboembolic disease, which is actually pretty common around the world. I'll be sharing some of that information with you as we go along here, but we're going to try to couple these things together in a way that makes it maybe easier for you to think about when to suspect VTE in your patient. Other installments of this series tell you how to manage that VTE when you see it, so we won't be focusing on that today. But suffice it to say that globally, the society guidelines that govern this issue have all sort of come down in favor of the DOACs, the direct oral anticoagulants, for the management of most cases of venous thromboembolism. So again, you'll see that in other installments of the series, particularly from my colleague, Dr. Jeff Barnes from the University of Michigan. But that's a pretty consistent recommendation around the world. And so, except in very special circumstances, probably we're going to end up, once you have risk assessed these patients, you've diagnosed them, and you've looked at the likelihood that they're going to need prolonged versus sort of a standard therapy, which is always grounded in anticoagulation. So let's start off by defining VTE. May seem straightforward, but it's not. Venous thromboembolism, VTE, is sometimes called VTED, venous thromboembolic disease. By consensus, includes deep vein thrombosis and pulmonary embolism. Now, from that point on, it can get a little complicated, believe it or not. Pulmonary embolism, for example, can occur with or without pulmonary infarction. Depends on the size of the clot that is embolized and the collateral flow to that area. And also depends on what part of the lung is involved. Even if you have an infarction, it may or may not be particularly physiologically significant. Infarction does cause greater symptomatology than an embolism without infarction. But the clinical impact of that infarction has a lot to do with the geography of where it occurs inside the lungs. Now, you can also include complications of DVT and PE in your thinking about what constitutes VTE. Post-thrombotic syndrome, used to be called post-phlebitic syndrome, is, as the name would imply, a complication of DVT. It's a fairly common complication. And again, the incidence of that can be predicted. But although technically speaking, it's not the result of an immediate clot, it's the after effect of all the inflammation that occurs around a clot, that can be considered part of VTE. And then for patients who have multiple pulmonary embolism, particularly those that are associated with infarction, you can come up with something called CTEPH, CTEPH, which is chronic thromboembolic pulmonary hypertension, which is a type of pulmonary hypertension that is increasingly common because of the increasing incidence of VTE, and is not particularly straightforward to treat, but does often include anticoagulation, really to prevent more clots being thrown to the lungs and making the situation worse than it is to treat an acute thrombosis. So if you take all of these together, VTE clearly represents a global public health problem. It's associated with significant morbidity and mortality, a tremendous economic impact that you can largely attribute to lost productivity, particularly among younger patients who suffer from VTE. But it really is a problem that is only getting worse as the population ages, as we have more of a problem with obesity, as patients who have diseases that predispose patients to VTE are living longer, because our therapy for those other diseases has gotten better. So these patients live longer, but they live longer at a threat of developing VTE. So this is a problem that's not going away. So if we think about what a DVT is, first of all, the D in DVT, remember, is deep. And so superficial thrombophlebitis doesn't count. It can be very symptomatic, but it doesn't count as a DVT, and those clots really can't embolize. The DVT tends to form in the veins of the lower extremity in the pelvis, although they certainly can occur in the upper extremity as well. And their nidus typically is around valve leaflets in veins. And from there, the clots tend to propagate proximally, i.e. towards the lungs, which of course is the last place you want them to go. But they can actually become rather large. And one of the startling things about large clots in a DVT is that the entire clot can sometimes embolize, and therefore has a much greater likelihood of doing a lot of physiologic and clinical damage to lung tissue if it does embolize. Pulmonary embolism, that clot, whether it comes up through the inferior vena cava or less frequently down through the superior vena cava, goes, of course, as those veins do, into the right side of the heart, and then can be pitched out to the lungs. DVT can't embolize into the arterial side unless there is a defect in the heart, like a ventricular septal defect or a patent foramen ovale, where that clot can end up over on the left side and get thrown out to the body, as we see in atrial fibrillation, for example, with arterial clots from thromboembolism. So again, pulmonary embolism almost always causes symptoms, although we do sometimes see small ones incidentally, particularly in cancer patients. But the ones that actually cause infarction of pulmonary tissue are the ones that cause greater symptomatology and also have more of a clinical impact in terms of the patient's ability to oxygenate after this happens. Post-thrombotic syndrome is characterized typically by a chronic swelling of the lower extremity. It's very, very rare to see post-thrombotic syndrome in the upper extremity. But this can be very painful. It can be very unsightly. It's often associated with chronic skin infections and with venous insufficiency ulcers. And so if you're unfortunate enough to get a VTE when you're younger, and then you develop post-thrombotic syndrome, this problem can be many, many years in duration. It can be quite disabling, may interfere with your ability to work, for example, particularly if you have these chronic ulcers. Patients are more likely to develop post-thrombotic syndrome from a DVT when they take longer to be treated, when the recognition and the treatment of the DVT is not as urgent as it should be, so that the clot has longer to set up and the inflammation around it can be greater. And it's also more significant, more likely in patients who are obese, which of course is unfortunately a persistently growing part of our population, pun intended there. So I spoke about the worldwide incidence of VTE. The best numbers we have these days are about 1 in 12. 1 in 12 humans on this planet, and we'll be talking about which humans are more likely to sustain this based on risk factors. But 1 in 12 are likely to experience a VT event, either DVT or PE or both, during their lifetime. And despite the fact that we're being much more aggressive with thromboprophylaxis, particularly around surgery and hospital admission for medical illness, despite the fact that we've had this significant pharmacologic advance of the DOACs over warfarin, vitamin K antagonist, the incidence of VT really hasn't declined over the last few decades. And that's because, as I mentioned earlier, these risk factors like obesity, longevity, the growing elderly population, and the diseases that predispose to VTE like cancer, COPD, CHF, and obesity also have grown in incidence, and we're able to treat them more successfully so patients maintain a longer risk interval because they're living longer with their chronic disease. That sort of counteracted the advancements we've made in diagnosis. For example, we now can diagnose by ultrasound as opposed to having to send people to venogram. We can diagnose by CT for pulmonary embolism as opposed to doing a pulmonary angiogram. And we have the DOACs. We have this smoother, easier, more patient-friendly treatment. And yet the total incidence of VTE hasn't reduced. We also see more post-thrombotic and post-embolic complications. We mentioned post-thrombotic syndrome and CTEPH. VT is associated with a 2 to 3 times increased risk of work-related disability. And that's due more to those chronic complications of VT than it is even to the acute ones. And we're seeing that as we study this more carefully, as we should be doing, there are probably some genetic markers that we haven't picked up on yet. The only one that we ever talk about these days really is D-dimer. And D-dimer is of limited utility in prognosticating whether or not a patient is likely to have a DVT or a recurrent DVT or PE. But I think we'll see more sophisticated markers coming to the fore in the not too distant future that may allow us to be more expectant in terms of preventing DVT and PE. PE itself accounts for about a third of incident VTE cases. About half the time, 45–50% of the time, we can positively identify the DVT source of the PE. But as I mentioned before, sometimes the entire clot embolizes. Even large clots can embolize in their entirety. And so you may not always be able to find where the DVT is or was in a patient who presents with PE. In fact, there's no significant relationship between the presence of a concomitant DVT, that is one you can still see when the patient has had a PE, and the development of unfavorable outcomes, including mortality in patients who have a PE. So if we start thinking now about the incidence of VTE, and remember that, as I said at the beginning, you can't talk about the incidence of VT without specifying in what population you're interested. Let's talk first about age and sex and how those impact the incidence of VTE. We know that the incidence of VT, and we're talking DVT and PE together, remember, increases markedly with age. We see it at about 1 per 10,000 persons in people under the age of 25, and that changes by 2 orders of magnitude to about 1 in 100 persons per year in patients over the age of 75. So always should be higher up in your differential list in older patients. In younger patients, the incidence is higher in women than in men. In middle-age groups, the incidence is considerably higher in men than in women. And then in the elderly, it's higher again in women, but part of that is a bit artifactual in that women live longer than men. And so there are more people out there to have this disease or this complication. That middle-age group between 55 and 75 years, where it's considerably higher in men than women, that's a historical thing. It's still there, but it's probably softening a bit. Much of that was probably due to men much more commonly being smokers than women. And we know that smoking is an independent risk factor for the development of VTE. On the other hand, women have these unique risk factors that are associated with their reproductive life, whether it's pregnancy or the peripartum period, or their use of oral contraceptives, or their use of female hormones for reasons other than contraception. All of those contribute to the increased risk that women have for VTE. Since some of those things are episodic or by choice, such as pregnancy, which of course is episodic, and oral contraceptive use is by choice, it's been suggested that men may have an inherently higher VTE risk than women, but the women sort of take over because of these external reproductive linked factors. Now, again, as I mentioned earlier, we're making great progress in identifying new biomarkers that may identify patients who are at greater risk for VTE, and that may eventually address that question of who has the inherently higher risk, men or women. It's probably pretty similar if you look at overall lifetime risk. And again, regardless of sex, about 1 in 12 humans will experience a VTE event during their lifetime. If we look now at the little bit we know about genetics and the history of past VTE as risk factors that predict incidence, there have been family and twin studies that have indicated a heritability of up to about 3/5 with some specific VTE syndromes. There's a wide range of genetic risk factors, some of which are quite profound, such as congenital antithrombin deficiency. That'll increase the risk of VTE by at least a tenfold, but fortunately, it's very rare. And then other things that we look for, like factor V Leiden, have a lower impact. And then there are even population-based studies that show that if your blood type is not type O, then you have an increased risk by maybe a factor of 1.5 compared to patients who are type O. I wouldn't base any therapeutic intervention on that, but it's an interesting finding. And again, it implies that there are greater forces at work here, determining who's likely to develop a VTE. What we do know for sure that you don't need genetic studies for is that if a patient has had a VTE in the past, that has a huge impact on incidence. The risk of recurrence after a first episode of VTE, and this includes provoked VTE, such as a patient develops a DVT under a cast. Obviously, in some patients, that's the result of the cast being too tight. But hopefully we don't put casts on too tight all that often. So probably what that forced immobilization did for some of these patients is to bring to the fore some sort of pre-existing proclivity for clotting. The risk of recurrence after first episode is about 5 to 7% per year. Overall, it's more than 50 times higher than in otherwise matched patients who haven't had previous VT. So if you're managing a patient who's had a DVT or P in the past, they present now with suggestive symptoms, that differential consideration should go way up on your list. And if you're one of the people, providers who follow these patients on an ongoing basis, is something you should be aware of in terms of giving them lifestyle advice and considering in some patients the need for long-term anticoagulation. Now let's look at the impact of other risk factors on incidence, specifically environmental and acquired risk, because they impact incidence as well. There's a long laundry list of things I could tell you that are significant contributors to VTE risk, and somewhat in order of importance. Cancer, surgery, trauma come first, and that they probably are the most important. But then underneath that, we have acute medical conditions leading to hospitalization, particularly pneumonia and COPD and CHF exacerbations. Immobilization, probably not just a long flight, but if you have other risk factors and then you put a long flight on top of that, maybe your risk goes up. We talked about the female hormone use, particularly estrogens, pregnancy for the same reason. Obesity, tobacco use, I mentioned before, and then chronic inflammatory conditions such as Crohn's disease, ulcerative colitis, rheumatoid arthritis. All of those are associated with a higher risk of VTE. We tend to think of these sorts of risk factors as being major or minor. For example, immobilization, unless it's spinal immobilization, would be a minor risk factor. Whereas cancer is a major risk factor. And then we think of them as being transient versus persistent. So I mentioned earlier a cast on a leg, that's obviously a transient risk factor versus a persistent risk factor, which may be, again, trauma that causes paralysis below the waist. Those lower extremities are always going to be at significant risk of developing clots. So we then think about provocation. VT occurring shortly after exposure to a major transient risk factor. You see our two categorizations coming together there, major instead of minor and transient instead of persistent. Like major surgery, can be readily characterized as being provoked by this factor, but that categorization can be much more vague when there are only minor risk factors, transient or persistent. And sometimes there's a combination of several minor factors, such as, again, a patient, say, with COPD who still smokes and is overweight and then takes an 8-hour flight. None of those by themselves are major predictors, major risk factors, but you put them all together and you're not surprised if that patient does develop VTE after that long flight. About 40% of the VT events that occur in the general population are classified as unprovoked because we can't see an obvious triggering factor that caused it. That sometimes makes the diagnosis a little harder to come by, and which is why it's important to have educational programs like this to remember that VT is such a prevalent disease, and that when patients present with extremity swelling or pain in the lower extremities, it could be due to a clot in the pelvis, or when patients present with breathlessness of sudden onset, whether or not they have hemoptysis, for example, we need to be thinking about DVT and PE in these patients, because the longer we don't treat it, the more likely they are to have complications. So I started off by saying that incidence and risk factor discussions around VT are conflated because, again, you can't talk about who's likely to get a VT without knowing what population you're talking about. Again, more than a third of VT events occur in the absence of an obvious provoking factor. And we continue to see incidence rates of VT going up. Again, lots of reasons for that. One is that we're better at finding it. When we relied on PA-grams and VQ scans to diagnose PE, we clearly missed some of them that CT angiograms now pick up. When we had patients who refused to have a needle stuck in their foot to have a venogram done of the lower extremity, we didn't see all of the DVTs that we can see now with ultrasound. So incidence has increased because of that. But again, on the other side, we have these competing downward pressures, such as better postoperative prophylaxis and longer therapy for patients who've had a DVT. So it's problematic that we continue to see this disease, and we know that it's not going to go away because these persisting rates are attributed to things that in some ways are success, such as better outcomes in patients with heart failure and COPD, patients who live longer with their cancer. We're going to see VT continue to be around as a result of issues like that. In terms of fixable factors, if you will, obesity is now recognized as the strongest causal lifestyle factor for VTE. There's a population attributable fraction, some experts say, of somewhere between 10 and 30% of the incidence of VT is directly related to obesity as a cause. Now, I don't mean to say that it's easy to treat obesity. It's certainly not. But to the extent that lifestyle changes, and now, of course, widespread pharmacologic intervention, sometimes surgical intervention can be brought to bear. When patients lose weight, they do tend to have a lower incidence of VTE. So we talked about strong versus weaker risk factors. There are gradations in these risks that we know about. For example, surgery and immobilization. A hip replacement is a much greater contributor to risk than is an ankle fracture. Previous VTE, as we mentioned, is a significant predictor of a new VTE. That's a much higher risk than inflammatory bowel disease, for example. Hormone replacement therapy or oral contraceptives, an important risk factor, but not as important as some of the inherited thrombophilias. So there's a lot of work in this space that has tried to sort of rank risk factors for venous thromboembolism. I think that the main thing is to be aware of the global risk factors and to see if they apply to your patient and see if there is a reason between the presence of those risk factors and the patient's presenting symptomatology to do a diagnostic study to evaluate whether or not there's clot there. Because again, patients have better outcomes when they're treated earlier and treated effectively. In terms of cancer type, probably the highest incidence of cancer that is associated with VT is pancreatic. Liver cancer, also quite high. Non-small cell lung cancer, more so than small cell lung cancer, is associated with substantial VT risk. Colon cancer and brain cancer, particularly high as well. Among the lymphomas, both Hodgkin's and non-Hodgkin's are associated with VTE risk. And then, in fact, breast cancer, prostate cancer, melanoma are all increased risk compared to the general population, but not as high as some of those others. So again, there is some ability to stratify a patient's risk. But what I'd love for you to take away from this more than anything is to remember that cancer of any type is a worrisome risk factor for the development of VTE. I mentioned earlier that in terms of VTE risk, hip fractures are probably the worst of your orthopedic injuries, which we know both orthopedic injuries and orthopedic surgeries that are more elective are associated with VTE risk. The other one that's particularly bad is tibial plateau fracture because it creates such a prolonged immobility. So those are things to think about. Orthopedists have really gotten more tuned in to the VTE risk of their patients, but often the follow-through is dependent on the patient's PCP or internist. So it's important to think about these issues when you have a patient with an orthopedic injury. Remember Virchow's triad? Virchow's triad from back in the late 1800s, Rudolf Virchow identified a three-legged stool basically as carrying the risk for venous thromboembolism, hypercoagulability, vascular stasis, and then injury to a vessel wall that brings platelets in and forms the nidus of a clot that may persist instead of clearing as it should. All of these things that we've been talking about as potential risk factors for specific populations of patients can be fed into the thinking of Virchow's triad. For example, cancer is certainly associated with hypercoagulability. It's associated with endothelial injury through inflammatory markers. And it's also associated with endothelial dysfunction and platelet activation. Whereas immobility from bed rest or travel really is just a vascular stasis area. Really just a vascular stasis issue. Trauma or surgery, again, all three legs of the stool in terms of hypercoagulability, vascular stasis, and endothelial injury. So Virchow had it right. We just have to think about our current diagnostic capabilities and think about the ongoing risks that these patients have for developing abnormal clots that may persist in vessels and ultimately turn into a DVT and could embolize. So I mentioned from the outset that this is a public health problem. As such, public health agencies such as in the US, the Centers for Disease Control and Prevention, have made education around VTE a priority. And just for your reference, because it's something your patients may have seen, the list of known risk factors per the CDC publication on VTE is quite small compared to what we've been talking about, but it does hit the high notes. They put cancer at the top. They put female hormone use underneath that. Hospitalization, surgery, or trauma in the recent sense are risk factors that we've identified before. That tends to go along with limited mobility. They do mention obesity and older age, which we've recognized as well. And then way down the list, they put previous VTE, which really should be up there at the top with cancer. And then, of course, they do acknowledge that there are some patients with an inherited or acquired thrombophilia. Family history of VTE is in the CDC list. I think that's a bit overblown. Again, there may be a genetic thrombophilia that plays into that, and so patients should be aware of it. But if, for example, your brother or your dad, broke a leg and developed a DVT under a cast, that probably doesn't really say anything about your risk of developing a DVT. So if we look at comorbidities, the things we tend to focus on first, these provocations for first-time events. Very interesting study that John Haidt did, published a few years back, 2015, I think. He looked at patients with a first-time VTE event and then looked at, in their medical records, the comorbidities that they've had within the previous 7 years and the provoking factors that were noted within the previous 3 months before that VTE event. And what he found was that patients with PE tended to be older by about 3 years than patients who had DVT alone. He found that among patients with PE, women were a little more commonly found than men. although in both categories, PE and DVT, women were slightly higher than men. And not surprisingly, in this review, the most prevalent comorbidity among all patients was cancer, both associated with about 1 in 5 cases of either PE or DVT. He looked at then some multivariate analyses to try to come up with comorbidities that may be more strongly related to PE than a DVT or vice versa. And what he found was that for heart failure, the adjusted odds ratio for PE over DVT is about 2.64 over 1.66. So, about, well, not quite twice as common that heart failure patients will get PE as opposed to DVT. Ischemic heart disease, PE is about 50% more common than DVT among patients who have a first-time VTE event. With atrial fibrillation, neither is a particularly elevated risk, but PE is a little bit higher than DVT. With COPD, probably not surprisingly, pulmonary embolisms more common with a risk factor of about 2.5 compared to DVT at about 1.5. Depression, interestingly, probably associated with immobility more than anything else. A little bit of elevated risk for PE, about 1.9 times, and for DVT, about 1.5 times. The odds ratios for PE and DVT were similar for other comorbidities that we think about a lot, such as ischemic stroke and inflammatory bowel disease. And then, probably not surprisingly to most of our listeners, temporary provoking factors that are more orthopedic in nature, such as musculoskeletal surgery or lower limb fracture, much more common among patients with DVT than those with PE. But of course, since every DVT has the potential to embolize, that may tend to equalize over time. So according to Height study, the independent risk factors for incident VTE, first-time VTE, were major surgery with an odds ratio of almost 19, active cancer with an odds ratio of about 15, neurologic disease, but specifically with leg paresis, an odds ratio of about 6, for hospitalization for acute illness, about 5, nursing home confinement, almost 5, trauma or fracture, which sometimes overlaps with major surgery, about 4.5. Then pregnancy, a little over 4, same as oral contraception. Then non-contraceptive female hormone use, although if that's used for cancer, obviously that's different. But if it's not used for cancer, if it's used, for example, for menopausal symptoms, the odds ratio is about 2.5. So BMI, by the way, in this study, now this was from 9 years ago, elevated BMI was associated with an odds ratio of just a little over 1. Clearly, that's changed as we've looked at broader populations, and also as we've seen the obesity epidemic only worsen in severity. Other risk factors that were identified for incident VTE, again, as I said at the beginning, there's a laundry list of these things that are associated with the incidence of VTE. A transvenous pacemaker, central vein catheterization, prior superficial vein thrombosis, a weak predictor. UTIs, probably because of age and infection, age and immobility more than anything else. And then, as we mentioned, there's a weak association with family history of VTE. What's really important, I think, maybe the most important finding out of Height's analysis, is that compared with residents in the community, hospitalized patients have about a 100-fold increase incidence, 100-fold increase incidence of VTE. And in fact, hospitalization and nursing home residents together account for about 60% of incident VTE events that we see. So that's a huge number, and it's immediately something that should come to mind when you're evaluating someone who may have a VTE. And we used to think that post-hospitalization VTE was really a function of whether or not you had surgery. It turns out that hospitalization for acute illness and hospitalization for surgery account for almost equal proportions of VTE, both between 1/5 and 1/4 of incident cases. The risk of VTE in patients undergoing surgery, again, we recognize this is a problem for many years, so we have a lot of data on it. Can be stratified on the basis of the patient's age, the type of surgery, and of course that plays into the amount of vascular injury there may be during the surgery, and also the length of the immobilization that may follow that. Smoking status, very important. We know that tobacco use is an independent predictor of VTE. And then, of course, if it's cancer surgery, or even if it's not cancer surgery, but the patient has active cancer, then their risk of VTE after surgery is going to go up substantially. We also know that the incidence of postoperative VTE is significantly increased once patients hit age 65 or older. And the surgical procedures that are most highly associated with VTE include neurosurgical procedures, major lower extremity orthopedic surgeries, renal transplantation, cardiovascular surgery, and of course, any surgery for cancer, although it's hard to tease apart whether that risk is coming from the cancer or from the surgery. We talked about total hip replacement being a significant source of VTE and prompts usually pretty good post-operative thromboprophylaxis, but not always. But among those patients undergoing total hip replacements, obesity and poor preoperative physical status are the critical risk factors for VTE, according to the American Society of Anesthesiology. And this brings up a topic for another talk someday, which is the whole idea of prehab before orthopedic surgery, as opposed to just relying on rehab. If you improve the patient's physical status prior to the surgery, if that's possible, then they're less likely to have all sorts of complications, including VTE. Now, risk assessment, as you can tell from all the stuff we've been talking about, can be fairly complicated. Just one thing that I found interesting in reviewing this literature that I think is worth sharing with you is the fact that we tend to think of a VTE risk assessment as being something that's done in person with long conversations with the patients and looking at their anatomy and looking at their body habitus. We had about a 3-year period where we couldn't do that because of COVID. And some authors in Europe actually came up with the idea of a virtual risk assessment for DVT, not so much for PE, looking at a combination of a virtual examination pathway and telemedicine technology to try to assess these patients for suspected DVT and at least decide whether or not someone needs to come in and get an ultrasound, because of course that can't be done by telemedicine. But those authors concluded that this is particularly relevant during pandemic time, particularly since COVID was considered to be a procoagulant condition. But while it's not a replacement for a face-to-face evaluation, this virtual risk assessment may be something that can be improved upon should we, it's going to happen. It's not a question of if, it's a question of when. Should we, again, need to resort more on virtual assessment than we do now that we're past the pandemic. And they published a nice little flow chart that talks about the key elements of history, what you can examine by telehealth in a patient, and then the decision-making pathway, again, whether patients need to be studied in some way, particularly with imaging, or maybe just get a D-dimer to try to exclude DVT when you've got limited access to in-person healthcare. So it's something worth thinking about, particularly if you're in a more remote area. So if we sort of start to summarize this and think about risk assessment models, so-called RAMs, the risk of VT in patients hospitalized for acute illness can be stratified on the basis of multiple factors that we've already talked about, particularly age, obesity, previous VTE, and cancer. I've mentioned heart failure and lung disease as being particularly bad risk factors for VTE. The models are pretty consistent in showing that we can identify which patients are at highest risk, but then on the other hand, we have core measures that have been done that look at VTE prophylaxis for everybody who's in the hospital. So these factors should be less important. What really comes into play is whether or not we need to continue thromboprophylaxis after a patient is discharged from the hospital for some time. And we've got a lot of conflicting data on the value of that. And even in those situations where we do have approved usages of drugs for extended thromboprophylaxis, what we see statistically is that physicians don't often use it. So again, that's one of the missed opportunities I think we have to reduce VTE risk in the population. These RAMs help us identify which patients, again, may be in need of longer prophylaxis, particularly if patients going back to the nursing home, for example. That's something to consider. In 2020, the American Society of Hematology did what they called an overview of systematic reviews, which is way up there in the statistical pathway, looking at hospital-acquired VTE. And they cited 5 RAMs risk assessment models that have been externally validated. The one from Joe Caprini, the Geneva, the Improved, the one from Niels Kucher, and the Padua score, and 3 of those 5 that have been evaluated in impact studies that actually seem to result in an increase in appropriate VTE prophylaxis rates, and that's Padua, Geneva, and Kucher. And what's probably not surprising to any of you about this is that if we look at the individual components of the Padua score, the revised Geneva score, they tend to look at the same things. I mean, with the risk factors we've talked about are common across the VTE spectrum, and they have different ways of scoring them and identifying who's at high risk. But generally, you're evaluating the same issues in all of them, whether you're looking at Kucher, Padua, or revised Geneva. So if we think about the latest recommendations for VTE prophylaxis in medically ill patients, there is still some emphasis on mechanical prophylaxis, which may or may not be tolerated well by the patient. But generally, most patients, and you can use one of these RAMs if you want to decide who's best suited for pharmacoprophylaxis. But generally, if you're sick enough to be in the hospital, you probably should receive some sort of prophylaxis, whether that's with a low molecular heparin or a DOAC. Obviously, things like renal function come into play there. But the fact is we've got to be cognizant of patients' risk when they're in this situation and try to provide appropriate protection from whatever risk factors they carry into their hospitalization, which then are going to be exacerbated by virtue of them being in the hospital. So I'll close just by talking about the impact of better recognition, better risk stratification of patients with VTE that we've seen over the last couple of decades, and what we've seen in terms of advancements in therapy. The factors with the most significant impact on practice in the last 20 years have been, of course, the move of most patients with VTE to outpatient treatment. That started with low molecular heparin as a bridge to VKA, which was logistically very challenging, but it kept patients out of the hospital when they had an uncomplicated VTE. We then eventually saw over the past 12 years or so the availability of the DOACs, particularly those 2 that don't require a parenteral bridge or lead-in, namely apixaban and rivaroxaban, as again making VTE a much more likely to be managed totally as an outpatient diagnosis. We've expanded wholly outpatient therapy to higher risk DVT, proximal DVT, for example, in an otherwise healthy patient. Whereas before, with the more proximal I got, particularly into the pelvis, it was felt the patient needed to receive parenteral therapy in the hospital. The DOACs have given us a lot more freedom about managing those patients in the outpatient environment, and now we're even extending that into PE. I'm of an age, which I won't disclose, but I'll tell you that when I was in training, a patient who had a PE diagnosed by any method was a patient coming into the hospital. No doubt about it. Parenteral anticoagulation for a while, depending on how bad the PE was seen to be and the patient's underlying comorbidities. Now there's growing experience, growing comfort, and less importantly, less medical legal concern about wholly outpatient management for patients who are graded as having low risk, and what that means is low mortality PE. The PESI score, pulmonary embolism severity index, and a modification of that called the simplified PESI are the best way to do that, it would seem, based on literature. And if you've got a patient with a simplified PESI score of 0 with documented PE, you really should feel pretty comfortable, barring other issues, either medical comorbidities or social concerns or economic concerns. That's a patient who really could comfortably be treated in an outpatient environment. So the take-home message here is think about all these risk factors when you've got a patient with a presentation that could be consistent with DVT or PE. Remember that DVT and PE can coincide with maybe diagnoses that are more common. For example, in a patient with pneumonia, you've always got to think about, could there be a PE underneath that infiltrate that you see on the chest x-ray? You've got a patient with a bad lower extremity cellulitis. Could that have been caused by a DVT, or might it coexist with a DVT? And you might want to ultrasound those patients maybe more than you would have in the past, because maybe they need more than an antibiotic to treat them. Take your knowledge that hopefully has been enhanced by this discussion of risk factors, and apply that to your patient management so that we can use the improved therapeutics that have been developed over the past few years. Again, judging from international society guidelines, most of your patients with DVT-RP are going to be treated with one of the direct oral anticoagulants. Thanks very much for joining us. And again, I encourage you to check out the other installments in this 5-part series on venous thromboembolic disease.